Hello, everyone, and welcome to aidsmapLIVE World AIDS Day Special 2023. I'm thrilled to be joined by an absolutely incredible panel to discuss this year's theme, Let Communities Lead, and have a bit of a chat about the inequalities affecting people living with HIV. If you have any questions, do please get them over on Facebook and Twitter, and I will pose them. I will try to pose them to our brilliant panel, who I will introduce to you now one at a time. So first of all, can we have Florence? Hi, Florence.
Hi, Susan. How are you, everyone?
I'm very well. Wonderful to have you on. For people who don't know Florence, she's one of the two co-executive directors at the Global Network of People Living with HIV, also known as GMP+. She is passionate about the health, rights and well-being of people living with HIV, driving tireless advocacy work to empower individuals regardless of their background and ensure their access to comprehensive SRHR and HIV services. Her leadership is instrumental in fostering inclusivity and effecting positive change with the global HIV community. Florence has a Master's of Arts in Communication Studies from the University of Nairobi. Very impressive, Florence.
Thank you so
How are
much.
you? How are you spending your World AIDS Day this year?
I have a number of events planned in Zimbabwe where we are all gathering for the International Conference on AIDS and STIs in Africa. And please do watch out. We will in turn also be doing a number of events for GMP+. Yeah.
Fantastic. So everyone, keep an eye out. See you in a sec. Can next have Erika. Hi, Erika. Lovely to see you again. For people who don't know, Erika Castellanos is a transgender woman living with HIV from Belize and currently residing in the Netherlands. Erika is the executive director of GATE, Global Action for Trans Equality, where she and a dynamic team work towards advancing the rights of trans, gender diverse, and intersex people. Erika, how are you spending World AIDS Day this year?
Susan, I think like everybody else and our colleague Florence have shared, we're going to be also partaking in different events in different parts, also online. And we're kicking off tomorrow from GATE with a webinar on trans masculinities and HIV.
Brilliant. That sounds fantastic. Keep an eye out for that. Chat to you in a sec. Next, can we have Kennedy or Idris, please? Idris has had a few technical problems, but here you are. Hi, Idris. Hi. Idris has over 8 years' experience in HIV advocacy in Kenya. He's a proud member of the network of young people living with HIV, SOTI Skika, and also chair of the LGBTQ liaison umbrella body, UTAFITI PWANI. How do you is that pronounced all together? How do you say that? I think they maybe
funny.
Yes, he is a human rights defender, holds experience in peer education, and was also part of the team that spearheaded the repeal of Article 162 and 165 of the Kenyan Penal Code in May 2019. Very impressive.
Yeah, thank you. And just like everyone else, I'm excited for the World AIDS Day. I'm currently in the steering committee of the Mombasa network or to organize for the World AIDS Day. Chairing and just like others, we are carrying out the activity. I would love, and community has been involved, just like the theme. So we are in the center stage of arranging for the World AIDS Day activity in Mombasa, and I'm excited because we're going to have fun on that day and connect with other people living with HIV. Thank
Brilliant.
you.
Looking forward to hearing more about that. Chat to you in a sec. And next, can we have Bruce Richman?
Hi, Susan.
Hello, Bruce. Lovely to see you again.
Great to see you too.
Yeah, Bruce and I were hanging out in Germany at a conference last week and spoke together, which was lots of fun.
That was amazing. Yeah, it was really good.
So I think most of the world know Bruce, but for those of you who don't, Bruce Richman has been living with HIV for over 20 years and is the founding executive director of Prevention Access Campaign, which mobilized activists and researchers to confirm and communicate the concept of undetectable equals untransmittable, you equals you, providing that a person living with HIV who has an undetectable viral load has zero risk of passing on HIV to their sexual partners. Today, U equals U has been accepted by the global medical and scientific community, and the U equals U movement has grown to over 1,000 U equals U partners in 105 countries. Wow, pretty impressive stuff, Bruce.
It's so exciting. And yes, I'm actually going to be using World AIDS Day as an opportunity to support those partners. We're hoping to continue to help folks get this message out on World AIDS Day and integrate it into so many different parts of the response, whether it's treatment access or ending criminalization or ending stigma or improving health equity. You can weave in that really important message and support all goals across the epidemic. So thank you.
Wonderful. Looking forward to seeing more of it over this week. See you in a sec. And finally, can we have Dr. Rageshri Dhairyawan?
Hi, Susan. Lovely to be here.
Lovely to have you. For people who don't know Rageshri, she's a consultant in sexual health and HIV medicine at Barts Health NHS Trust and an honorary senior lecturer at Queen Mary's University of London. Her clinical work, research and advocacy focus on improving health equity for marginalised populations, particularly at the intersection of ethnicity and gender. She's currently chair of the steering group of 4M Mentor Mothers. Hi, 4M ladies who might be watching, and a medical advisor to NAS. She has previously held national positions at BASH and Beaver, most recently working on Beaver's EEDI review. Very impressive. So, Rageshri, what are your plans for World AIDS Day?
So I will be at work. So I'll be doing a clinic, which is HIV and hepatitis co-infection, and then I'm doing a ward round. But our department tends to do some kind of awareness around World AIDS Day on the day. So we really try to challenge stigma amongst our healthcare professional colleagues.
Brilliant. Wonderful. Thank you. So can we have everyone on, please? Brilliant. This is a bit like the Brady Bunch, seeing you all like this. So people have already been sending lots of questions over. And the theme of this World AIDS Day is let communities lead. Florence, what does that mean to you?
I think let communities lead for me means an honor to the work that we have been doing for many, many years, that finally all the work that communities across different networks, from an individual, from institutional points of our work, it's getting recognized. And that with the leadership of UNAIDS, everybody is coming together on World AIDS Day and hopefully into the next few years going forward to attention and position the leadership of communities. And we need to look at the word leadership as not engagement, because technically we've been engaged, we've been brought to rooms tokenistically. We are looking at leadership and all the facets and the principles around leadership, which is trust, authenticity, clarity of the work that we are doing, measurements, investment, all of that is centered now around communities of people living with HIV and key populations and other vulnerable populations to contribute to the HIV response. I think that's what excites me, and I'm hoping to see some actions around that.
Fantastic. It's very exciting. And I'm really glad you raised the issue of tokenistic engagement, because so often, for many years, that's what we've seen. Erika, why do you think that community leadership is so important in the HIV response?
Thank you, Susan. When it comes to leadership, and it's a word that is used so often, and with very little depth, because people like to throw it everywhere. Lead, let communities lead, take leadership positions. And sometimes we don't unpack what it really means. But we really need to have a very critical approach at being leaders and taking leadership in the HIV response. For far too long, like Florence said, it has been tokenistic engagement and being on the table and having a voice, which is all good. It served the purpose, but that should be in the past now. Now it's time for us to lead as people living with HIV and looking at leadership from the different approaches, analyzing who is not on the table, which are the voices that are missing, who are we here talking on behalf of, recognizing that I cannot talk on behalf of everyone, but I can consult with people who are not on the table to bring their voices and also their leadership positions, and look at the intersectionalities in leadership. Leading as a person living with HIV, leading as a woman, leading as a trans person, it all comes with challenges. It challenges in the patriarchal system, challenges in the HIV response, in the health architecture system, and it's time that we tackle those challenges.
Absolutely, definitely time that we tackle those challenges. And Idris, how important would you say community leadership has been in the HIV testing response? Are you hearing me, Idris?
I think I got lost for some.
Yeah, I was
had a
just
glitch.
wondering about testing and community leadership.
Yeah, so I can say from the country that I am in, Kenya, inequalities against especially key population. One of the organizations I work for is Hapa Kenya, which works with the key population, that is men who have sex with men and transgenders. We've seen testing levels not being as high as it should be because of different challenges regarding homophobia. We've seen in this year, this has been my longest year in all my life. Due to the challenges, we've seen organizations of anti-LGBTI coming together to fight community-led organizations. And at some point, we've had to close down operations where we offer comprehensive healthcare services, including HIV testing to our community. And this has let us down because we've lost some of our clients, and our worry is some of them are into ART. So those initiated on ART, and because of homophobia, they've had to run away, go to countries that we are not aware of. And World AIDS Day really means for me is community ownership is reflecting on getting those persons who are not able to access HIV services out of stigma and discrimination. That is mostly fueled by homophobia and also bad laws that, like in our country, that we have, which over time we've been fighting to making sure that communities are at the center stage of HIV testing and comprehensive healthcare services. And if we fight these bad laws, HIV testing goes up because we are freely able to come for services at the public facilities and also community-led facilities.
Thank you. Thank you very much for sharing that, Idris. And it's really shocking in terms of the increase in homophobic laws that we're seeing at the moment, and hostilities to communities. And I was going to throw it to all of you. What do you think are some of the other barriers that are being faced in relation to community leadership?
Can I start, Susan?
Yeah, do please.
I think that some of us in the healthcare profession and research can be a bit of a barrier to communities, because I don't think we're used to letting communities lead. So I think, you know, there needs to be a real shift in power, which means people letting go of power. It means that we need to listen better. We need to also support people so that they can lead. So, you know, can we support you by training? Can we do the research? Can we help you with the research skills so you can do the research? Can we help you develop healthcare services in a way that's more accessible? So I think there needs to be a bit of a power shift. So I think this World AIDS Day is a great time to carry on talking about this.
Yeah, absolutely. Thanks for sharing that, Rageshri. And I'm also conscious of the fact that very often communities, you know, we aren't paid for our work or our time and aren't given the proper support. Is that something that you'd like to be seeing change, Florence, GMP Plus?
I like to say this about, and thank you, Dr. For sorry, didn't get the name. For that mistake. I mean, for that intervention around shifting the power. And I think most of the time, again, just like Erika said earlier, there are words like shifting the power that people like to use as concepts. But I really would like to see that there's some actions to them, because shifting the power means trusting that the communities for whom you're giving this power can be able to shape and define things. Shifting the power means not coming to us with your theory of change, but coming to us so that we develop from the needs of the communities. And even for us who are sitting at global levels, understanding our privilege and sometimes our tone deafness from where we are sitting, to take that down to the actual communities who are facing the experiences on the ground. The experiences that Idris has faced being in Mombasa as a person who's living with HIV but leading interventions targeted at people living with HIV are very different from me who's sitting and just doing policy. So I can go to Idris with a predefined idea of how I think they need to work. I need to sit in humility. Again, the qualities of leadership needed now, I feel, cannot be the qualities that have predominantly been used to run or to work around the HIV system, or rather the sector. So then coming back to your question around, just as I finish in my last minute, around tokenistic and non-tokenistic, I think we have existed largely, we being communities both affected and living with HIV, as patients, service recipients. Our bodies have been pathologized so much that I doubt if sometimes people see who we are or see us and our capacities as people. It's why the words come in terms of we have to be helped, we have to be supported. And we need to start to shift this mindset. And I debunk even within my own team this word support. It's power taking as well. It's not support. It's give people what they need to be able to make the decisions and in the agency they have. So do we have the agency in the first place, or are we constantly looked at as patients? Bruce will tell you when he gets to talking that it is one of the reasons why everyone is still scared of U equals U, because they don't see us communities who can actually think and make a decision with the information that we are given. So we have to, and it's also just from but there's a risk, but there's this risk. It's all these things that constantly take away the power. But before we get to the power, are we even seen? Do people really acknowledge people living with HIV, key populations, as people with agency, with the ability to make choices that are good for us? Because then if we start from there, then we can begin to truly talk about shifting this power.
Thank you very much. And yeah, Bruce, I like to come to you on that point. I mean, what barriers do the community face in terms of leading with the U equals U message globally?
Well, I think one of the biggest barriers, and this really picks up exactly with what Florence was saying, is that you know, we're seen in the response often as the problem. We're seen as numbers. We're seen as our viral load numbers. We're seen, you know, and not seen as us as we are the solution, and to trust us. You know, when we were starting this campaign, which I think all of you were here in the very beginning, we would hear so often, well, this message is dangerous for people with HIV. If we give this to people with HIV, they won't understand it. Or there's this, you know, still this lingering kind of understanding, or I should say misunderstanding, that U equals U is just about people with HIV having sex without condoms. First of all, that should be enough. We should celebrate people with HIV being able to have sex without condoms. It's fantastic to be able to have sex and intimacy and conceive children without worrying about, without fear, right? That should be enough. But you have folks in the response who just kind of peg it to that, and that scares them. That scares them. And you know, us having pleasure, us having sex, having agency, being able to have information to make decisions about our sexual health on our own, you know, scares them. So in many ways, we work with that, and we say, look, you know, trust us, believe in us, and U equals U is also about ending the epidemic. When you tell people about U equals U, more people are willing to go to get tested for HIV. We see that data. People are willing to go on treatment and stay on treatment and stay in care and get to an undetectable viral load that reduces new transmissions. So it's good for everyone. And you know, we're coming up still against that, you know, that lack of trust and belief in people with HIV, and we want to keep changing that and celebrating that our pleasure, our sex, this is our time, you know, to invest in us, give us this information, and we will thrive and we won't pass on HIV, and that's good for everyone. That's a win-win. So we've really trying to approach this long-standing kind of devaluing the lives of people with HIV over folks who are negative by saying, look, investing in us is good for everyone. You know, this is good for everyone. See us, invest in us, invest in our well-being, and everybody wins.
Fantastic. Yeah, that's such a powerful message. Rageshri, sometimes some healthcare professionals are still holding back on the U equals U message. And actually, I heard last week when I was in Germany, a healthcare professional had told a patient that actually it wasn't true. You know, what can we do in terms of educating other healthcare professionals who might not be working in HIV?
So I'm just shaking my head because I'm really shocked to hear that. It's really disgraceful that has happened, because there is so much evidence. We've had evidence for years and years and years now that for the evidence for U equals U. And I feel quite proud to work in the UK, where we've been quite strong on the message, I think, as healthcare professionals, with Bruce's help and everyone else's, since 2018. So, you know, we've been telling our patients, and when we see them, that U equals U, and talking about the evidence behind that. So I think perhaps it's on us as healthcare professionals to make sure that we're talking to our colleagues. And one thing we did at the British HIV Association was to survey our colleagues and said, you know, what do you say about U equals U? And from those results, we were able to do some teaching. So maybe that's something that can be done in other countries as well. So healthcare professionals making sure that everyone knows what to say and make sure they understand the evidence.
Fantastic. Erika, what are your thoughts?
And so I think, you know, I just want to follow up on this stat before I talk a little bit about the barriers, but I just think that U equals U is the perfect example of let communities lead, and how communities have really pushed it forefront and really battled with all kinds of professional legislators, researchers, scientific community, and really brought not a message, a life-saving tool forward. A life-saving tool, an advocacy tool. It's just, you know, the empowerment that comes with it. So I just wanted to emphasize that. And looking at other barriers, there's so much multiple barriers for the community. And speaking particularly from the trans and gender diverse community, I have to say that, you know, this current rise in anti-democratic governments, populist, right-wing governments, coupled with the anti-rights, anti-gender movement, is perhaps the biggest risk and the biggest barrier for our community, which is trying to erase our very existence. When our existence, when who I am is questioned, the dignity of being a human being is eradicated, and there is nothing else that can be done. So everything around prevention, access, care, everything is just chopped down because our very existence is not respected. So I think that's the biggest issue. And many times when we talk about the anti-gender movement, people think it's about trans people. It only affects them. You are wrong. I just need to say you are wrong. It affects everyone. It affects democracies. It affects women's rights. It's a movement that is trying to eradicate the women's rights that we have fought for so many years, and so many sacrifices have been made. So I think we need to be very aware that this is not a struggle only for the trans and gender diverse community. This is a struggle for all of us.
Yes.
Absolutely. I very much agree with you. And I just wanted to ask you all, how you feel about the increase at the moment of populist governments and far right ideology, and it really seems that people who perhaps have held these views feel much more emboldened to be sharing them now, and that's something that we're even seeing in the UK as well. I just wondered if anyone would like to share their thoughts.
I could go ahead and say what comes to my mind. I think for me, I will speak generally and then just go into the AIDS response. I think personally, it's the global solidarity around human rights is either diverted or fading or has somehow disjointed. And you can see how it's easy to define with moralistic landscape or viewpoints how other people are more human than others. We see it every day. And it sadly has found its home in something that is very, very important for public health, which is the AIDS response. And it's being used to sort of, again, dehumanize people who really don't need we don't need to start looking at people from a very pathological or a very simplified way of life. And I think in my thinking, it's because for the last 10 years, we have grown as a movement, the HIV movement, largely in a very pathologized biomedical way. The research, the science has gotten us to the point where we can comfortably say, if you are HIV positive, take your treatment and are virally suppressed, you cannot pass the virus sexually to a partner. We can hold that as the benefit of all we have done for the last 10 years. But it came at a cost to our humanity. And we have to start to talk about that behind the people who don't need to pass the virus are human beings with their needs. Behind the people who are not now dying of AIDS or won't die of AIDS if they are on treatment are people living with HIV who live longer and require, aging with HIV interventions. We need to go back and we need to start making our HIV and AIDS movement about our humanity, because I feel like we lost that. We talk about 95, and we are very happy about a country reaching 95 and are okay that those numbers are missing key population figures. We are okay with it. We get that caveat, and no matter how many meetings I go to, people ask these questions and I don't see any tangible action around answering this. Who then are the missing of the 95? I see us talk about inequalities around HIV, and we need to address inequalities around HIV, but there are 9 million people not on treatment right now. Who's asking who they are? I was at Fast Track Cities in Amsterdam, and the city of Amsterdam only had 9 new infections in 2023, 2022 or 20, I don't know which year. But as we clapped, I was sitting there asking myself, who are these 9 people? Why do they get to be the 9 people who got HIV? If we start asking these questions, then we will start to understand the unique challenges that a group that we don't want to talk about or to accept that are here with us are actually facing the challenges that they are facing, so that we can address those challenges directly. When we continue to blanket, name or go safely into things that are comfortable for us to talk about, we will never get the 9 million people. We will never reach the 1.5 million people who continue to be getting HIV every year. So for me, it's how do we make this response human again?
Thank you so much for sharing that point. That's a really powerful message. And we've got a couple of questions that have come through, I think, regarding people from particularly marginalized communities. So one question is, first of all, is what can be done to improve the rights of drug users with HIV? Would anyone like to take that?
I can start if
Thank you.
others oblige. And you know what I think, to improve the rights of any community, but particularly if we're talking about people who use drugs, I think we need to humanize people. So start humanizing the individual, and that's the first step. Uh, and looking at them from a holistic point of view, really addressing the issues about how these communities are criminalized and prosecuted, and how many times gatekeepers like police or other enforcement agencies really exercise violence against the community. So one way you can support is making sure that the issues people who use drugs have are front and center and reach politicians, reach decision makers, and that we advocate for laws that humanize people who use drugs, but all other people, respecting the dignity of the individual. I recently saw something shared around women who use drugs in particular. And as I said, you know, when we're talking about groups, even within marginalized groups, we need to unpack the different intersectionalities. And we're always seeing women are always on the losing side, and it's time to change that. I'm tired of always having to bring out the issue of the inequality and the power dynamics, and how women are always the one on the losing side, but also the ones that need to come and fix things.
Absolutely. Yes, I will definitely
Yeah.
come back about the intersections affecting women. But another linked question that someone sent through is criminalizing sex work leading to more HIV infections?
I would say, let me go. Yeah, I would say absolutely yes, because oftenly, as I alluded first, I'll tell you for sure, if violence is put against these specific communities we are talking about, and I'm happy that people are saying, let's humanize let's unpack what we call numbers. When you say we have 3,000 sex workers in Mombasa, those are human beings who, at the end of the day, if they're living with HIV, and they have to go to the streets to work, and yet they're being violated. Most of them shy away from even accessing ART care and support. And as someone has said, the previous speaker, totally agree with her, saying that most of time women are on the losing side, and mostly sex workers who are women oftenly in this case are more affected, and because of power dynamics that come with it, you see patriarchy still is an issue. And with all that, I know of many sex workers who have families, some of them who have partners who don't know the type of work they do, and most of time they'll shy away from talking about their HIV status. I know of women who have to put their drugs on maybe a container of maize flour in the country that I live in, just to survive living with, rather taking ART, and sometimes not even them giving the husbands and the partners HIV. They are the ones who mostly are at a higher risk of getting the HIV virus at the first place. But still, inequalities make them not to access services. And what does this mean? If someone is a sex worker, most probably they're having a client from 1 person to 10 people in a day. And those are numbers that relate to human beings and relate to new infections that are on the rise. Yeah, sure.
Thank you so much for sharing that, Idris. And I'm very conscious that women with HIV face intersecting forms of stigma, discrimination, and disadvantage. And Florence, can I ask you about some of the main challenges of many that women with HIV experience?
I could talk about this the whole day, so please stop me. I think at the start, I would say it's what people do or how people talk about our bodies. That is our whole conversation. And I think, and speaking from my experience, and I have a support group, and I mean, we talk as women where we are, it's how right from the moment you enter the health facility, what is told to you becomes a responsibility, whether you want it or not. And for women, it's different. Women walk into the health facility either because they are pregnant or having to require some sexual or reproductive health intervention. And that already starts off a conversation around who's your partner, you know, like the child, your responsibility to the child. And with every visit, as a woman, you become diminished and diminished and diminished, because with every visit to the clinic, regardless of whether you're HIV positive or not, you as a woman is just a vector of risk, or an entry point to finding the men who are not hard to reach, you know, the whole story. And it's how we have organized the interventions for HIV and centralized women leadership. So these are the things we're calling out. What is women lead? I remember sitting in my country writing proposals called Women Lead and actualizing these interventions where the leadership actually is not really leadership, but constantly putting the heaviness, as Erika says, the fixing of the things on the woman. And it starts with, then it's the woman's responsibility to disclose. No one tells us it's our responsibility, but it is the women for not disclosing. It becomes the job. I'm concerned, what will the guy say if I tell him my status? I don't know about his. So it's the responsibility. It's the woman being left out of a celebration 18 months after delivery because her child did not turn out HIV positive. She failed. It's how we do our programming, where we define the victory and the lack of victory around women, making sure the HIV virus doesn't pass on from them to someone else. But we don't give them the tools to support this from happening. And this is the actual, women cannot take a more advanced treatment because they don't know how to plan their pregnancies. And they will get children and then they will not go to the health facility. No one talks about the distance. No one talks about the social economic issues that come from the disparities of gender, equal pay, access to work, decent living, etc. But we continuously deny women the optimized treatment, the access to services, because women cannot think around their children's safety, etc. And I think this is really wrong, because if we stop to see women as women, then we can see the valuable contribution that they can bring instead of making decisions for women. So we make it, I think that is the one thing, the gender equality issues come out of exactly how we look at women and women's participation. But in the sector, I feel like it's just started from how people speak about women, people address women's issues, and we need to be the women leadership that we are currently seeing come up and stand up. Erika and I are pretty much some of that leadership right now. And there's many of us jumping up into and getting the opportunity now. It's a shame it's 40 years down the line, we are seeing more women in leadership now. But can we be allowed to lead then with our way? Because we cannot be expected to do the leadership in the ways that have existed. We are not men. We are not aspiring to lead as men. But our leadership style is soft, or it's, there's always all these things. Because it's not the norm. So I think for me, the challenges are of stigma, of discrimination, of lack of equality. Women, even in wars, take the we saw during COVID the existential crisis around gender-based violence on women, and the number of children, young moms, now dealing with, because gender-based violence on young girls has also quadrupled, and making young girls be young mothers in a society that is not ready to address some of these things. So the issues on women are many. To address them, we need to stop or start to talk differently about women living with HIV, or women most at risk of getting HIV in the HIV response.
Thank you so much, Florence, for sharing that. And Erika, trans women are 66 times more likely to have HIV. What do you think is driving this?
So I think it's linked to a question that you asked before about criminalization. It's because there's this fight about our existence. And so it's a different components, but it applies also to sex workers and other criminalized groups. It's stigma and discrimination. The criminalization, it contributes to stigma and discrimination, not only from society, but institutionalized stigma and discrimination, to access services, to being able to voice their needs, the reduced access to condoms and safe sex practices. When there's criminalizations in many parts of the world, you cannot even carry condoms or other safe sex practices with you. The barriers to healthcare and education, when you have to go and access healthcare in a public hospital that is run by a government that tells you you are a criminal. It's not safe in many parts of the world. The violence and coercion that impacts our community, and always having to deal with different issues and other. I will say I never like to put a competition of what issue is more important, right? But when you are worried, the moment you wake up and open your eyes, you don't know if you're gonna make it to the end of the day. Whenever you go out to the street, to the supermarket to buy your food, you are not sure if you're gonna come back home. When those are the kind of issues that worry you and take your time, there's nothing else that is more forefront. Survival takes the first place. So HIV many times for the trans community is behind in the background. The first thing I need is I want to remain alive. And that's your number one struggle. And I think other marginalized groups are also dealing with this.
Yeah.
Thank you. Oh my goodness. Yeah, thank you so much for sharing that. And Rageshri, I'd like to ask you about the fact that in the UK, there are now more people who have been diagnosed with HIV but have fallen out of care than there are people who have yet to be tested. And as Erika mentioned, so often it's the other issues that people have going on in their lives that's so much more pressing than HIV itself. What's your experience in the UK in terms of people who have disengaged with care?
I think it's something that we see a lot of. I think it's finally getting recognised a bit more when it comes to policy and funding for research and things, which is good. But I think, yeah, it's very common. And we know that often the reasons are because we haven't designed services in mind so people can get to services for all the reasons that Florence has said. So some of the, socioeconomic issues, the structural issues, the sheer issue that HIV is not the most important thing for most people, for many people in their lives. And, a lot of it is about the social and structural issues that affect a person. So I think it's really important that if we do see a person in clinic is to talk about what else is going on for them outside of clinic. So kind of what are the issues that might make it harder for them to stay healthy, to stay in care, to take their medications, but then to do something about it. So, for example, do we have someone in clinic who can give advice around benefits claims or housing or immigration or domestic violence, or can we refer elsewhere? I think I work in London, so I feel very, very lucky that we have so many HIV third sector organisations here who provide peer support and who provide a lot of those services, such as counselling, etc. But I think just identifying what are the issues for the person in front of you, what's going on in their lives, trying to anticipate this before they aren't able to turn up to clinic. So giving them support before they fall out of care and then supporting them to get back in, and really monitoring who is in clinic and who isn't. So we need better data systems as well and sharing.
Thank you. Yeah, it's great that there is that level of support, particularly in London. And Bruce, I'd like to ask you about the USA. Often when people think about America, they think about it being a fabulously rich country. But the reality is, for many people living with HIV in the USA, they aren't virally suppressed. What's driving the inequalities that we're seeing in the USA?
Yeah, it's shocking. The adjusted viral suppression rate in the United States is 57%, and so folks aren't even getting access to the treatment to be able to experience you stay healthy and not pass on HIV. A lot of it's really what we talk about in the field all the time is the social determinants of health. You know, kind of looking way back, it's not the fault of the individual. It's the circumstances, the life circumstances, the policy circumstances, the systems that people grow up in and or live in and work in on a daily basis. And in the United States, we're a system that you can see more and more now with our politics was really built on white supremacy, and is built that way, and it's ingrained in our systems. It's the kinds of access that kids who are from Black and brown families grow up in, the communities, the lack of access to education, or the food deserts, or it's the divestment in communities of color in the United States that has been going on since the very beginning of the United States. And so it's like trying to change a system that was, you know, that these inequities are these are examples of the manifestations of the system. So when you look at why are Black and brown folks and Black women in the United States not being able to access treatment, it's about the system. And so, you know, what are some first, we need to change the systems. We need to vote horrible people out of office and make sure Trump is not elected. We have to do vote. But we also need to look at practical things right away where we can reach people, where we can engage, especially in the South and in the United States, and in Black and brown communities in the South. We need to look more at indigenous populations, what's happening, the Native American population. There's why is it happening? Because that's the way America was built. America, I mean, it's like, you know, so we have to undo, you know, a lot of the system, radically disrupt. And in order to do that, and then I'll stop, is we also need to really work together. So we have to disrupt the silos in HIV between treatment and prevention, or PrEP and U equals U, or criminalization and treatment. We really need to work together, especially now, because the right wing is getting stronger and more organized, while a lot of us continue to kind of fight over territories or funding. So now it's time. Now is our time. And what we can show now is that investing in people with HIV, regardless of who we are or our background, making sure we have housing, making sure we have food security, making sure that we have access to gender affirming care and clinics that are stigma free. When we stay healthy, that's good for the country. That's good for the economy. That's good for the for public health, and that's the way to end the epidemic. So if we can come together and really celebrate that this is our time as people with HIV, invest in us, regardless of our background. You don't have to like us. We hope you like us. We hope you celebrate people with HIV. We want you to, but regardless, investing in us, making sure that we're healthy and have what we need to thrive is good for everyone. Like I love that frame. I think 2024, more of us will be really motivated around that.
Fantastic. Yes. And I think we really need to shift from thinking about survival to thriving with HIV. And Rageshri, thinking about the UK, there seem to be some parallels, even though we do have high rates of viral suppression. Your research found that there is inequity between people of colour and white people with regards to HIV in the UK. What did you find?
Yeah, so we looked at kind of 17 years worth of data from all of the clinics in England, and we looked at viral suppression, people on treatment, people how advanced their HIV was when they were diagnosed, and we found that some Black groups and some Asian groups were more likely to be diagnosed late with more advanced HIV, less likely to be in care, and more likely to have viral rebounds, showing that they weren't able to take their treatment regularly. So this showed that, even in the UK, well, this study was in England, but where we have the NHS, so treatment is free for everybody, it shows we still have really profound inequalities for lots of different reasons, particularly faced by communities of colour.
Yeah, and that's shocking. And is that what you find in the Netherlands, Erika, as well?
In fact, I am very open to say that that's what we find everywhere in the world. And the reason is because we operate in a health system that is deeply colonialistic, deeply geared towards white people and privileged people. So until we really untangle all those dilemmas that are entrenched into how we offer health services and how we look at people and their dignity and value, we will never achieve equity and equality. That's why people of color and people that are non-white are always on the other side of when it comes to access.
Thank you, very much. And Florence, what do you think is the impact of colonialism in the HIV response?
The very definition of everything we do. It's funding. Who's giving the funding? How are they framing the funding? How are they giving it? How many Black-led global organizations even exist? Who is sitting in places where decision making around the treatment we are going to use, how it's going to be used, is done? For a long time, and I've been in the global work since like 2016, 2015, 2016. I think there are so many calls I walk in and I'm surprised that I'm probably the only Black community representative. Or there's probably just two of us, a Black person or a person of color. But then on the other hand, you have all these doctors, researchers, modelers, etc. What language are they using? Are they using language that all of us can engage with? They come in there. We have to, and I have to remind people, communities come into meetings, but we did not take the extra hours of classes to understand data and all those things, but we have to. And even after we've had to, again, the credibility of our decisions continues to be questioned because it didn't come from this peer-reviewed. Who reviewed? Who wrote? Who did? And it's those things that then we have to constantly have to adapt to, these crazy requirements, these crazy donor requirements for communities to even access funding. I will just speak randomly about what happened this year. The community from East Africa has been facing, basically Africa in general, the worst form of attack around rights, particularly people who identify as LGBTQ and sex workers. They have faced the most outrageous attacks this year. But even the meetings that had to go and take place before allocation of budget to just go and support rescue is allowed, takes longer. And we see the difference. We saw how quick everyone was ready to jump and offer support when there was the war in Ukraine and Russia. But we didn't see that level of commitment when people we work with who give us the things we need for our own theory of change to donors were facing this year. So we see the disparities. It's in the system, as Bruce says. And I actually go and say, if communities are not leading, if there is a system that continues to create inequalities for Black people, for people of color, for marginalized communities, if I can sit in GNP Plus and see that the most unequal person almost my age is a gender non-binary person almost my age, and they are standing at the back of a privilege line just next to our intern who's 19. That needs to shock me into fixing and to seeing this person. So these are some of the conversations we need to honestly have. It's if I, as a Black woman, has jumped 11 hoops to be a director at GNP Plus, I shudder to think what my colleague, who's still at the back of the line, almost at my age, will have to jump. So these are the things we have to talk about: leadership, about the system, and allowing for these conversations to take place very, very honestly will begin to shift how we want to do the next 5 years of responding to HIV or the next 10 years or post 2030. And I think these are the things, just echoing Erika and everyone else, we must really bring to a conversation moving forward.
Absolutely, it's so important moving forward. I've got a question that's come through from the audience. How can we encourage more women with HIV to get involved in clinical trials? Who would like to take that?
I think the first step, if I just start the
Just before
conversation.
someone else jump into, allow me to say, yeah, yeah. I just wanted to second Florence because it also adds to the previous comments she made. Allow me to say that meaningful engagement has to be really meaningful engagement. Um, I'm tired of in community involvement, meaning just a checkbox, tick box of we involved one person or two. As Florence has said, we have to really give the decisions of the affected population. It might be women, it might be youth, it might be key population to lead the agenda of what is affecting them, to act on the theory of change on what is affecting this specific population, and so as women. Women need to be at the center stage of their
Thank you.
conversation.
Thank you.
I'm
Thank you very
tired
much,
of
Idris.
yeah,
Yeah, go back to Erika, was just answering about women in
yeah,
clinical trials.
absolutely.
Thank you, Susan. I think there's a couple of things we can do to increase the engagement and participation of women in clinical trials, and we can start by targeted recruitment efforts because not enough is being done for the inclusion of women in clinical trials. But this will also mean that we need to address barriers to participation, identify and address the specific concerns. It might include things like childcare responsibilities, transportation issues, but also issues around safety and privacy, because many women are concerned around safety and privacy. We need to increase educational initiatives so that women and other minorities can understand the importance about the involvement in clinical trials. But we need to start collaborating with healthcare providers more closely, including in being included in study design, implementation, and community engagement is key for that.
Absolutely, yeah. Florence.
I think that's what Erika just said. Let's be included in the study design, because what exactly are the clinical trials about? Because if you started to include women in shaping the research question, the study design, then we will talk about the things that matter to us. I shudder to think of the fact that very, very few advanced decisions are made with very little information around how treatment, around how prevention interventions actually affect women, but also who's doing research on issues around sexual health for women as we are aging with HIV. And all this data is missing and must start to get organized, because then we will have decisions made around our health with data that we can also contribute to shaping.
Brilliant. Thank you. And we've only got 2 more minutes to go. How has this gone so quickly? So I've got one quick question for all of you. I'll start with you, Rageshri, and go around. Could you say one change you'd like to see in 2024 to improve the lives of people with HIV?
Oh, you've asked me first. If anyone wants to jump in before me, please go ahead while I get my thoughts together.
Yeah, anybody who wants to go, if we could just, anyone could jump in, we'll do it in a, who'd like to go?
I can start a conversation because there's something that is burning me inside.
Yeah.
And it's this martyrdom competition that we have in putting, like, who is the one suffering the most, and trying to like compete about who is the most, population being victimized the most and suffering the most. I think that needs to stop, and we really need to be united. I need to start the conversation from the fact that I cannot talk about everyone, but I need to ensure that everyone is mentioned and every voice is heard.
Fantastic. Who'd like to go next?
I would love to
I would like to see.
Go ahead, Idris.
Okay. No, it's okay, Florence.
So I just wanted to say I would love to see.
I wanted to say I would like to see an increase of community participation for people living with HIV.
Wonderful, thank you. Florence?
I would like to see the resources and the space and the opportunities for communities to lead.
Florence gone.
Yeah, wonderful, thank you. Bruce?
collaboration among community organizations. Like the organizations on this panel are so amazing, and we already collaborate with you and continue to want to collaborate together. And say zero. I can't get off without saying that the WHO brief is saying zero risk. Everybody can say zero now when it comes to U equals U. So let's.
Yay. And finally, Rageshri.
I had some time to think. I was just thinking about solidarity between organisations and different causes, and just realising that other people's problems are our problems as well. So more of that, please.
Absolutely, more solidarity. Well, thank you all so much for joining me today. It's been an absolutely brilliant discussion. I'm really looking forward to seeing all the awesome stuff you're going to be doing for World AIDS Day this week. I'd like to also thank Disruptive Live, who have streamed the show and done wonderful technical wizardry in making this possible. I'd like to thank all of you for joining us today. I hope you all have a wonderful World AIDS Day, and I will see you next year when we'll be back. Thanks very much. Bye-bye.